Labor Access, and it's organized with Working People's Coalition. Today's webinar is on building a robust campaign for health security of informal workers. In today's webinar, we'll discuss the current state of security, health security, and social protection for informal sector workers, existing legal statutes, policies that protect workers' health and their security, and the need for their implementation. We will also discuss invisible economic and social factors that affect health security of workers and their families, and identify new ways forward. Finally, we will also provide strategic and tactical inputs to the initiated ESI campaign. I would like to introduce today's moderator. So today's moderator is Sundar Babu. Sundar Babu Nagapan is a social activist, a public policy analyst, and a grassroots educator. He is currently affiliated with the National Secretariat of the Working People's Coalition. Sundar Babu, are you with us?
Yeah, thank you. Thank you.
Yeah, you can take it ahead.
Yeah, thank you. Thank you. Good morning, everybody. Welcome to this webinar, which is the second part on the WPC's campaign on ESI. This webinar would be on building a robust campaign for the health security of informal workers. Why? I mean, Mithali had given the key points that we will be deliberating upon. But why do we take this up? Why do we take this up? It's because the health security of ESI covered workforce is being compromised and threatened, even though the workers' contributions are rising exponentially. Workers are increasingly being treated unjustly, and their money is being misused to subsidize the private health sector. Recent data shows that only 37% of contributions were spent on workers' benefit. And in the last decade, the contributions have increased over 5 times, even though the membership has increased only 2-fold. The contributions which the ESI collects from workers' wages far exceeds what it spends for their benefits. There is an across-the-board decline in spending, which only means that the access to benefits are getting reduced. So there is a huge shift in medical care spending for super specialty and hospitalization towards the private sector. Unlike the health ministry, which struggles to deliver poor the public health service because of inadequate budgetary commitments, the ESIC is not constrained for resources. The ESI has the potential for being developed into a universal social insurance benefit for the entire workforce, including the informal sector, if there is a political will to do so. And such a political will can come only with the assertion from the working classes, who need to realize the critical importance of universal social insurance benefit, both as a unifying force for the working class as well as the social wage. So it is in this context that WPC, in solidarity with the other workers' organization and people's movement, is raising its voice for asserting the legitimate health security and particularly the informal sector workers' social protection. So in this context, we will be discussing the topics which Mithali had already spelled out, which is about the current social security status, the existing legal statutes, the issues that are invisible factors which are affecting the health security of the workers, and finally looking at some tactical inputs, some strategic inputs to the ESIC campaign. So, so I'm just directly going to the speakers to hear from them. And we can deliberate on this later. So we have 3 important speakers with us, Dr. Mohan Mani, Dr. Amit Basole, and Dr. T. Sundararaman. So to begin, straight away, I would like to request Dr. Mohan Mani to initiate this deliberation by sharing his ideas. Dr. Mohan Mani is a visiting fellow at the National Law School of India, University, Bangalore. He has been a labor researcher working with trade unions for the last 30 years. That's a brief introduction about him, and he might share more when he speaks. So I would request Dr. Mohan Mani to initiate this discussion on ESIC campaign, the ongoing ESIC campaign.
Thanks, Sundar Babu. And first, disclaimer, the PhD that I've just got is honorary PhD from the WPC, so please ignore that. Having said that, I just want to raise just 2 or 3 issues and then leave it to the other panelists. One issue is, I mean, like all of us know, that the ESI is geographically very much concentrated, which is understandable. It's geographically very much concentrated because it is it was started as a program for the organized sector. So it is where development exists that ESI is strong. And so it is precisely in those places where you need good healthcare services, because it doesn't exist well enough in either the public or the private sector, that ESI is the weakest. For instance, if you look at the statistics, and if you compare the total number of ESI beneficiaries to the population, for the country as a whole, it's roughly a little under 10%. But when you go to particular states, like for instance, in Bihar, it is just 0.7% of the population. This is data for 2016-17. Just 0.7% of the population which is covered as beneficiaries by ESI. For UP, it's 3.2%. And for the Northeast, it is a ridiculously low number. So you see the type of coverage, and that it is precisely in these states where, and compare that with Tamil Nadu, which has 20% coverage, and Haryana, which has 42% coverage as beneficiaries to the total population ratio. So you see that it's precisely in these large states, which are poorer states, where you need ESI coverage and where it's the poorest. This sort of differences also occur between the metropolitan cities and the rural areas. And so, for instance, in Karnataka itself, where all the districts are covered by ESI. In Karnataka, in Bangalore, there against a sanctioned strength, the number of doctors who are present in the ESI dispensaries is 72%, whereas in the regions outside Karnataka, it is nearly 32%, which reflects both the state of the dispensaries and also very critically, another question that needs to be answered, that doctors are reluctant to go to rural areas. So what is the solution to that? You might have the infrastructure, you might have everything in place, but if the doctors don't go there, then what do you do? All these are questions that need to be addressed if you're going to look at broadening the coverage to the whole of the informal sector. Because when you're broadening the coverage, it also means that you're moving from the bastions of the formal sector to across the country, because the informal sector exists everywhere. And so that is one question that I would like to raise for discussions. The other question is to do with the financial situation itself. I agree with Sundar Babu that the expenditure of the government on what is really needed is probably much lower than it should be. But if you look at the statistics itself as to what is happening, the net revenue, which is the contribution that comes from workers, as compared to the total expenditure per worker, it was around 9,200 crores in 2019-20. It's decreased sharply. By 2021, it is only 2,800 crores of rupees, the net revenue per annum for ESIC. This is very understandable because two things happened. One, the government reduced the total percentage of contribution from the employer and employee from 6.5% to 4%. And second, it's done that at precisely the time when it is expanding the ESI coverage to various other sectors of employment, which is a welcome move. But if you do that along with decreasing the contribution from the employer plus employee, what you're effectively doing is trying to underfund the ESI, and probably as a prelude to privatization of the assets of the ESI itself. So what is the answer to that? In fact, if you look at the 2022 estimates, the estimates is that the per capita income per worker is about 4,461 rupees, as against a per capita expenditure of 5,193 rupees, which means there is a net negative balance as far as the contribution from workers is concerned. And ultimately, the negative balance is covered up because there is a surplus that exists with the ESI corporation, which is invested. And it is the invested surplus which is actually making the ESI still profitable. How long will that last as the surplus gets whittled down upon? As it should, because you need investment. You need to invest if you want to spread the ESI. You cannot do that without investment. Today, yes, if you look at the balance sheet, the ESI corporation, as on 31st March 2021, had a balance in the balance sheet of 96,000 as its free reserves of 96,000 crores of rupees. It's a huge amount. But if you look at that also, if you look at it after saying that you are expanding the ESI to all unorganized sector, informal sector workers, you will see that the per capita surplus, if you look at it, will be in the order of around 2,000 rupees per worker. So this is not a substantial amount of money when you look at the type of expansion that is envisaged. So if we are going to ask for expansion of the ESI without an equally strong demand that there has to be a substantial recapitalization of the corporation itself, then we are going to be in a situation where we are probably in expanding the corporation to the unorganized sector, to more and more workers, effectively killing the organization itself, which is probably what the government would like to happen in order to privatize all of health insurance itself. These are questions that I would like to raise. And finally, the last point that I would like to raise is that when you are looking at the workers, the primary requirement of workers for healthcare is in the is basically essentially in the outpatient care, which means that it is in the dispensaries that you need to probably put in the maximum amount of resources to start with, not in hospitals, not in medical colleges, which anyway benefit only the more privileged class. You may say that this will be workers' college. They never exist as workers' college. Essentially, you need to strengthen the on the ground the possibility of workers to be able to actually access free and adequate outpatient healthcare. I'll stop here and I'll leave it to the other panelists. Thanks.
Sorry, thank you, Mr. Mohan Mani, for sticking to the time. It was perfect dot on time. So yes, you are right. Because this the program being geographically concentrated has been the biggest issue, because from the beginning that is one limitation which we have, which we see when we ask for an amendment. These things are to be taken up. And thank you for sharing the details on the financial aspects of it. And you are right, because the WPC also holds the position that we need to equally demand for more dispensaries at the ground level, because the data very clearly shows that there is an decline in outpatient numbers in the context of ESIC than the utilization of inpatient. So that actually shows that there are some issues related to the way outpatient services are being provided. So thank you so much for this input. And next, I would request Professor T. Sundararaman, who is a former Executive Director of National Health Systems Resource Center and also former Professor and Dean of School of Health System Studies, Tata Institute of Social Sciences, Mumbai. And he's currently a member of Steering Council of the People's Health Movement. So I welcome Dr. Professor T. Sundararaman to share his thoughts on this webinar.
I'm going to take into a PowerPoint mode also and share a PowerPoint slide.
Please, please.
I hope this will be visible to you. Is this visible?
Yes, yes, yes.
Okay. Now, the slides have got a lot of information. I shall not cover all the information. I am going to use it to construct the logic of the presentation and what you need to be knowing. And the slides can be shared by the organizers with all of you later. So I will make them available to you. I must first recall that the ESI book was brought about almost on par with the Beveridge Act in the UK, which was a comprehensive social security act. And we should not actually limit it to the only Healthcare Act, which has been a problem also. It is a very good set of benefits, medical benefits, certainly, but sickness benefits, which is compensation for wage loss, maternity benefits, disablement benefits, dependence benefits, even funeral expenses, rehabilitation and unemployment. And therefore, it is a fairly comprehensive issue. There is a whole range of criteria upon the quantity of the benefits and the eligibility from when a person after the premium payment has started is eligible. And this also is one of the better coverages that you have anywhere in the world. The quantum of benefits is also continuing that for funerals, for maternity, for vocational rehabilitation, for unemployment. These are all in the law, and at some point they are currently available. Another fact that if you see the actual disbursement of these benefits to intended beneficiaries, as we have got from demand side supply studies, it can be very low. In fact, healthcare has relatively a higher access compared to some of the other benefits. It is counterintuitive. You don't really expect that also. Now, the coverage under the Act greatly increased, as I think the organizational note also pointed out in the last 20 years. And part of the increase was due to 21,000 per month. But here is a problem. If the salary rises above 21,000, it drops. And it's never very clear why anybody who wants to continue with this coverage should be refused this coverage, because every principle of insurance will hold that to include the higher sector within this coverage brings in a whole lot of insurance actuarial benefits that you are really going to get better off person. So actually why you have such a clause is this. Now, workers in many other establishments have been added on, plus workers in educational institutions, private medical institutions, and a lot of powers have been given to the states to how much they can include by their board. Now, the coverage by geography has also increased with a commitment to achieve a full coverage by 2022. I would like to know what is the official position on that. There are certain workers not covered. With the Social Security Code, some of these get covered. But we know the workers in plantations and mines have separate code. The central and state government employees have their own insurance schemes. And there are some definition of seasonal factory So there are certain categories. Now, establishments not yet notified, domestic workers, home-based workers, gig workers, contracted workers. There is a number of areas where the dialogue has been ongoing for a considerable time. States have a certain range of powers in which they can include, but in effect, the coverage is not included. It's not at all clear why this has not been done, because there is really very little objective grounds why it could not have been done. Because remember, this is a comprehensive social security package, not just a healthcare package. Now, one of the reasons why coverage has increased in recent times is because the organized worker definition has been relaxed to include a whole lot of contractual labor. So it's organized industry, which has a clear employer. And for the contractual labor, it is the immediate labor contract. Now, in nature of labor contracting and its shifts that has taken place even under public sector undertaker, there may be an immediate contractor, then an intermediate contractor, and then a last level labor contractor. The last level labor contractor is not a formal person and has 10 or 15%. So therefore, his accountability is low, and then it goes to intermediate and then the immediate. The mechanism of collection of the premium is rather good, but even the communication that they are covered to the laborer who is covered can be extremely low because of the way these operate in different circumstances. So in sense, there is studies now available that shows the actual act of being covered. The premium has been paid, deducted presumably from the salary and the employer's wage and paid into the kitty. But the awareness that this payment has been made is not there, and the entitlements that comes with it is really not there. As others have pointed out, the number of beneficiaries is greatly increased. However, if you look at demand side survey, so this I have been using the NSSO 75th round survey, but now I have not updated I was seeing in the last 2 days, 2022, ILO has put up a study, which is Shaktivel Selvarajan team, their study, and that also shows a rather similar issue, that only 10.3% of those who are presumably covered or ought to have been entitled to this coverage have actually aware of the coverage itself. I also think that if you look at the hospitalization rate, the 75th round does capture ESI, and you can see the hospitalization rate has not gone up significantly, but the out-of-pocket expenditure to hospitalization is significant enough to cause catastrophic health expenditure. But as compared to other forms of protected financial protection for healthcare delivery, it does better. So the out-of-pocket expenditure will be, say, 19,000 in private sector and 2,847 in the public sector for a person with ESI, as compared to, say, a government PMJAY, where it will be 3,299 and 21,000, or private insurance where it is even higher. Remember, out-of-pocket expenditure in hospitalization should be zero. It should be zero. The fact that you are having a significant out-of-pocket expenditure and in the private sector means there is a substantial degree of double billing by many techniques. And if you look at the catastrophic health expenditure, which is the aim is to actually prevent that, the catastrophic health expenditure remains very high, though it is less than those who are not covered. So 60% of the population who are eligible will, if they are not covered, experience catastrophic health expenditure, whereas 32% will expenditure in the private sector if they are covered by ESI. So there is a gain. In the public sector, the gain is much more, meaning that if you are looking at a ESI hospital with or without coverage or a public hospital, your chance of encountering catastrophic health expenditure is higher than if you have insurance. I mean, so therefore, at some point of time, insurance is very inefficient way of providing financial protection. And these are really happening more where you have outsourced the care provision to the private sector. I'm going to skip a little bit of, and I'm looking at some of the issues which have been said. One of the problems, and I'm going to make this general statement and then leave it to elucidation later. I need to write about this. We have a lot of information. I think the notion of how modern healthcare is organized to a population, and a population is not a geographic population. ESI has a population defined by certain criteria of employment in across places. But how you deliver it, I think the modernization that has occurred, the more modern concepts that have occurred across sectors has not reached ESI. I am worried, for example, that we still use the word dispensaries. Dispensary has a certain connotation as different from primary health centers. Primary health centers provide a package of preventive, promotive care. Their primary role is to screen everybody, make sure they do not develop diabetic complications, hypertension, heart attacks, and also refer them in time if they develop. Here, what you are implying is, having been diagnosed at a particular stage, you will get dispensed medicines at some point of time. The entire preventive promotive role is not there. I know of hospitals that have hired private, corporate, things like HealthSpring to provide occupational health coverage for their workers. Some of them are sedentary workers who do a proper health checkup and are able to save a number of people with diabetes and hypertension from a whole lot of non-communicable diseases which affects the working class nowadays from being affected on that. And yet these concepts of the organization of service delivery has not really entered health sector, which seems insulated from the larger dialogues that happens in the WHO and in these areas. So the ESI hospital is 1 per 8.6 lakhs. Dispensary is 1 per 88,000. The average population to primary center thing is 3,000 to 5,000. What? We are saying you need a primary healthcare point, place person looking at it, 3,000 to 5,000. You have that for insurance medical practitioners. But the lot of insurance medical practitioners that one has interacted with really are not equipped to do an understanding of primary care. They are dumbed down to a very limited role, which doesn't really help, nor have they the support, nor are they part of a system of care. At some point, there is a problem in the way this is implemented. And the bed strength is also, against one, you have 1 per 6,000 beds. So there is a huge supply side gap. So when there are 99,000 crores of surplus, it goes into rather wasteful forms of tertiary care without actually a well-planned and distributed deployment of that. I really think that at some point, the full employer-employee contribution at the earlier rate would have been quite adequate to provide this care. I've looked at issues like Germany and the Japanese, and they are able to provide a fairly sufficient range of care. I think this, the earlier speaker was saying it only comes to 2,000 rupee per person extra. That's 1 GDP per person extra, more than 1.4 GDP per capita extra on healthcare. That's quite a bit. In some sense, I'm not saying that we don't need. I think we need up to 5% of the GDP per capita. I mean, 5,000 rupees per GDP per capita at current rates. But having said that, 2,000 is not to be frowned at. And I think even within, though I do agree that there's a case for greater investment, but I do think there is a much, much greater role of service delivery that can be organized simply by understanding how service delivery has to be organized on that. And part of the problem, which I've written about in many, which I've talked about in many situations, is the center-state relationships. The solution that the ESIC tends to think is that if they take over the hospitals themselves, they do better. That's partly true. And when you go to scale, it won't do better. When you have got only a few hospitals that you are taking over, you may be better delivery of care. But that's still hospital care. That's still not primary care. So if you include primary care and if you include the problems of scale, taking over and centralization is not going to really solve it. And at some point, you do require to actually look at how we are going to manage the different things. Central paradox is that, which other speakers have also mentioned, is that unlike the general health services, where a lack of budget is a key constraint. And apparently over here, within certain conditions already specified by the earlier speaker, there is no such lack. But at the same time, our utilization is extremely poor, and that requires a substantial degree of governance reforms and even the understanding of modern healthcare delivery and how that requires to be. You know, when the ESIC jumps into the word modern healthcare delivery, they pick up the word digitization. So a whole lot of interest now is digitize, digitize, digitize. But the problems are institutional, and if you digitize the wrong institutional design, you are going to actually compound the problems rather than solve the problems. So at some point, yes, digitization has much to offer, but the real problems are more than the digitization reforms. It's not as if the ESIC has not been internally seized with reforms. There has been a number of reforms, but all these reforms are advised by consultants, international and national, who come from the new public management neoliberal schools of thought. So for them, making it public to making it responsive to private incentive, to monetary incentive, seems to be the change point, which actually is not true, because what you really need to do is to organize this in the nature of public goods, and you don't really have enough thinking within the system as to what that really means. So most of the reforms are like outsource this, bring in monetary incentives, get more private providers on road. And you have been doing this for 20 years and it's not been working very well. So therefore, to come up with this as the solution, rather than examining why past efforts to do it. In fact, the ESIC has put together all the reform packages that have been ever associated with neoliberal reform, but yet not moved elsewhere, and therefore there is a time to be taken differently on this. So I'm not getting into this. I'm just going to have 3 closing slides on what is to be done and build an. So my general point is, reforms has meant market-based reforms, but that's not working. It's not a question, it will not work. My contention is it has been tried and it is not working. Need to do better. One is the expansion of the care, the expansion of the basket in principles of insurance that will lead, expand to districts, ensure registration, include all workers irrespective of income. For home-based workers and self-employed workers, etc., federate them and empower the federation to act as a surrogate employer. This has been done in different situations, and it can be done with cross-subsidies from other risk pooling groups, and work out modalities for units less than 10 days. The delivery of medical benefits basically link primary health entitlements to accredited health and wellness centers as alternatives, ensure same comprehensive package in ESI dispensaries. So let the dispensaries continue, but upgrade them into comprehensive primary care units and supplement the HWCs. Ensure that catastrophic health expenditure is measured and eliminated. At some point, that has to be an outcome measure of your program in the hospital care. And it can, if you really do it well, you will deprivatize hospital care. There has been a trend to privatization. We see in Europe a whole trend to deprivatization, and what it takes, and you will need to deprivatize. You need to integrate with the Ayushman Bharat, and there are some very good examples of Thailand. Why, even if you do not integrate at the top, you can do much better integration at the district level if you get the principles right. And finally, rethinking the institutional design. Strengthen the existing tripartite structure, rethink and reassert the federal structure, give a better buy-in to the state government, improve the governance of health sector delivery, and make financing responsive to requirements, but not in market terms. Meaning, if there is one facility providing a much higher volume and variety of care, that has to be reimbursed like an insurance scheme. The total volume and intensity of the care that was provided the previous year. So in some sense, how do you actually do that? And you do need to make sure that they do not get disrupted by pandemics and the entire package of social security benefits. Healthcare is what I am most comfortable in talking about. But I think similar things apply to the other elements of the social security package. I think social security for all the time has come. And in this whole discussion of right to healthcare that has begun now, re-intensified after Rajasthan's effort, I think the contribution, the integration with ESIC is going to be crucial to the whole nation, because your 93% of the workforce which is unorganized must be covered by an entire social security package, which will include this. So this whole approach, I think, has a future. And though it hasn't done so well in its past, but it's still done much more than people give credit for. Thank you.
Thank you. Thank you, Professor Sundararaman. It was very enriching. You took us through several issues across, from the details of the benefits to understanding the issues of benefits and eligibility. And you are right. I mean, we agree with you on the question of the cap that is there, which was discussed in the WPC meetings. That how it is contributing or contributing positively or negatively to the beneficiaries. So that discussion was continuing with us, and your input is a valuable input on that. And yes, the out-of-pocket expenses have been a serious concern, because that has been all the recent studies, including the ILO studies, shows that very clearly. Thanks for sharing on the financial aspects as well. Yes, your view on the dispensaries is definitely important, because we had used different words. So we will now be careful in using that, in emphasizing the public health centers more. Because the campaign itself was looking at the preventive healthcare as well. So in articulation, we had used the dispensaries, but we'll remove it. We will use the PHCs instead. And also this, your explanation, or your enriching on the digital aspect also is very important, because there was this confusion which we faced during recent times, post-COVID phase. There were some studies that looked into the ways the labor welfare boards function, particularly in Tamil Nadu. And then we saw this digital thing contributing in a way in the context of expanding the membership, but it was also leading to the new issues. And thanks for the input that you gave about the issues related to the institutions with regard to the digital question. Yeah, finally, what is to be done? The things which you have said are very important. We agree with the WPC stands with that. Thank you so much for those inputs, and we would look for future partnering with you and working with you more on this aspect. So next, I would request Dr. Amit Basole, who is a professor of economics and head of Center for Sustainable Employment at Azim Premji University, Bangalore. Welcome, Professor Amit.
Thank you. Thank you, Mr. Sundar Babu, and thank you for the organizers. I'm actually learning a lot here. In fact, probably learning a lot more than I can really contribute, because my area is not health. I'm primarily a labor economist. So I don't have a very good understanding of certainly not of the ESI, but even the broader health insurance and social security architecture. I have only a very basic understanding. So I think I will keep my remarks very limited. I'm curious to also hear the questions that come. I'll keep my remarks limited to some aspects of the Indian labor force and some macroeconomic aspects of how important it is to devote adequate resources to the kinds of things that we are talking about. Those I'll stick to those kinds of concerns. So I think all of us know about the continuing problem of informality, which is also partly why institutions such as the ESI, which were set up for the organized sector, as we saw, have not really been effective in helping unorganized sector workers. They were not set up with that vision in mind. And I think at the time that these institutions were set up, there was at least a hope, a belief that in the ensuing decades, in the subsequent decades, the Indian economy would indeed formalize adequately, would structurally transform itself such that more and more of the workforce could then become part of whether it is Provident Fund or employee state insurance or any of these other structures that were set up. Now, that structural transformation did not occur as was expected, with the result that we have the situation which we have now. We have a very complicated labor landscape. Some workers are indeed covered, about 10% or so, in these kinds of structures, but the vast majority, about 90%, are left out for one or the other reason. And what makes it even more complicated is that the kinds of subcontracting chains that were alluded to by the previous speakers make it difficult to assign responsibilities to employers and so forth. So even though we've had a strong increase in the number of salaried workers in the country recent years, in the last decade in particular, self-employment has been declining, casual labor has also been declining to an extent, and to the extent that in urban India now, the salaried workforce is the major part of the workforce. More than 50% of India's urban workers are salaried workers, but only in a very loose sense that they are paid a regular monthly wage. They are not working in formal enterprises or establishments. They often don't have access to Provident Fund or other kinds of benefits as well. So we have a salaried workforce, but we don't have a socially protected workforce. So that broad fact that we all have in mind, which is that 90% of India's workforce is informal, unfortunately, in a way, it still remains true. Now, having said that, I was really interested to learn how ESI operates and the way you are thinking, you meaning WPC and others are thinking about how to incorporate the organized sector in this, because one thing that I am hearing out of the discussion is that, or at least this is how I took it away, maybe I'm mistaken, that a strong investment or increased investment in public expenditure on health seems to be crucial to make this work. Whether we are talking about effective delivery, or we're talking about generally bringing down out-of-pocket expenditures, which are extremely debilitating at this point. All of this comes down to the fact that in India, we have consistently failed to allocate the adequate number of public resources to health. And we really stand out when we compare ourselves to some of the countries that were mentioned earlier, including Southeast Asian countries like Thailand or Vietnam, and certainly when we compare ourselves to China, which is not a very good comparison anymore, but in the 70s, 60s, 70s, 80s, when India and China were not that different from each other, we still see a huge difference in the level of commitment to primary health care publicly provided. And that has a long shadow. The fact that China did this in the 60s and 70s made a huge difference in the 80s, 90s, and 2000s to them. And the fact that we did not do it at that time makes a big difference to us today. So for me, from just an economist point of view, and as I said, I'm not an expert on these issues, it underlines the importance of publicly provided healthcare, quite apart from the insurance issue. Right? There is, of course, still a question to be discussed about how insurance would work. And I agree with the previous speakers that the combination of privately provided healthcare and publicly provided insurance is actually quite a bad one. You end up with a lot of perverse incentives. You get costs building up without healthcare being actually provided, and so on. And we are seeing that happen with Ayushman Bharat and other examples. So I don't think that's the way to go. The final point I'll make, and then I'll stop. I'm eager to hear the questions and the responses of the other two experts. Is that going ahead on the labor front? It seems to me that the proliferation of the gig economy, which is now no longer just a metro phenomenon, but also in other smaller towns and so on, and the pressure that the government is putting on these things like digitization it seems this will result in, and the proliferation of UPI and those kinds of payment methods and so forth, digital platforms, etc. All of this is really transforming informal work in a very big way. So, we are used to thinking about the informal economy as a cash economy. And to an extent, that is still the case. But a lot of India's small economic transactions in the informal economy are no longer as much cash as they used to be. As a result of the pandemic and other reasons, cash is actually declining in importance. And the digital economy is taking up. Now, I'm not saying that this is in itself good or bad, but it provides a way for us to think about how we are going to gather information that we previously might not have been able to gather on people's expenses and incomes and so on, and how we might be able to reach them more effectively than we could have in the absence of such a digital infrastructure. So I know that many of us are rightly skeptical of this sort of digital mantra, and I'm not saying that we should fall for that, but we can be thinking about how to use the infrastructure for making a case for what we want to make a case for. So I'll stop here, and I can come in on any questions as needed. Thank you.
Thank you, Dr. Amit Basole. This is very important because what you had highlighted in the last seemed to be the also the point of debate that is happening inside the WPC. That how do we approach this whole issue of digitalization? When they say that it contributes in a big way to redressal mechanisms. So it has given an opportunity window there. And also it provides some level of advantages in quantifying the gig platform. But on the other hand, does it actually contribute to the real issues is what, as Professor Sundaraman was mentioning, that whether the core issues are addressed or not, that's a big concern that we too have. So in designing the campaign and designing our campaign material, the designing our petitions, these inputs are very important. I mean, we are thankful to all the three speakers for providing us very, very critical inputs to our campaign. So to start the discussion, I would request the audience to share their views. To begin with, I also want to introduce Dr. L.A. Sami, who is also part of the campaign team, the lead campaign team, to initiate by giving his first comments. Sir, I think the mic is in mute, sir.
Am I audible?
Yes.
Okay. So first of all, I think I appreciate and also thank all the panelists for giving a very, very concrete and concrete way for the action of the WPC's ESI campaign, especially Mohan Sundaram and the professor maybe. They are not.
Sir, is it possible to speak closer to the mic? It's not very clear.
Am I? Is it
Yeah.
better?
Yeah, it's better.
Okay. So I'm thankful and also appreciate all the speakers for giving us a very, very clear and workable solutions and also the way for actions in the ESI campaign. I think that was remarkable and I want to give it. The second one is I'm really taken up and at the same time, which is much more concrete, is we are not market driven, it is solidarity. I think this is something that we need to take in, and that is what we have been also speaking about, that we need to reach the people where the demand comes from them, with better understanding, better consciousness. That is something that is very interesting. And the third one is that it's not dispensaries, but it is primary healthcare centers. That is something that we need to speak more and we need to articulate more to as a demand for political will. And on the other dimensions, like the privatization of these insurances and the ESIC and all that funds are being diverted and deviated and not even invested in the public sector has to be a big question of how we need to organize ourselves to demand political will that it is people-centered, not market-centered, or the supply and demand-centered approach of the economy. I think these are something that is very, very good takeaways for our campaign. And I'm sure that all of us, including the panelists who have been committed and who are activists in a different way, will be able to join in the campaign to see that everyone in the labor, especially working people, are not left behind in the inclusion of the universal social protection for all. Then we will see collective responsibility and a conscious responsibility of everybody to join hands to see that there is a policy, there is a lobby, there is a positive change in making all laborers, all working people in the same hands. This is what I wanted to give as the comment. And I'm really happy that this panel has been one of the wonderful inputs for action. Thank you very much.
Thank you, sir. Thank you. The audio was still a big challenge for us to hear fully. So we understand your anguish on the absence of political will in the context of the ESIC and this social protection at large. So thank you so much for the inputs. We would like to hear from other participants about their reflections on what they felt on these three presentations. I can see Mr. Prasanna raising his hands.
Oh, thank you. I can speak now?
Yes, please.
I'm from Goa, president of the AI2C Goa State Committee. And I actually thank WPC for conducting this seminar. All the three speakers have made a very, very valuable points, and that gave me clarity as to what various problems I was attending here for implementation of the ESIC scheme here in Goa. I have noticed that here in Goa, there are 13 dispensaries and they are functioning like an office from 10 to 5, whereas the industrial estates are functioning all 24 hours. So this dispensary should have been functioning all 24 hours. That is my first observation. And that has been, and also it will expand the coverage and contribution of the outpatient attendance of the ESIC scheme. I've also noticed that there is an enlargement of the scheme because there is a new type of workforce is joining. But contract workers, labor force is not getting covered, not getting benefit at all. I have also noticed that the misuse of the ESI funds, the workers' contribution, employers' contribution, this fund is getting misused. I have noticed that one big hospital in South Goa has been established. It was supposed to be a turnkey project that is build, operate, and transfer. A small hospital was supposed to be enhanced facilities to 100-bed hospital. And it was supposed to have been completed in 2008. It took 2012 inauguration on the eve of the parliamentary election. But precisely that inauguration was taken as a plea that the hospital has been complete. It is build, operate, and transfer, but hospital was not complete and it was inaugurated. Crores of rupees of the workers' funds have been spent. The huge DJ machine set, very most modern operation theater, the centralized AC, very, very modern concepts and equipments have been purchased, but they have not been put into operation at all. And after almost 12 years, that hospital has been handed over per force to the Hospital Development Committee, which was incomplete even at that stage, and more than 6 crores worth of work was incomplete. Now, this, I'm just giving this fact because others should know how misuse of the ESI funds are taking place.
Yes, sir, but it will be useful if we discuss specific to the campaign that we are planning. So some specific input, sir.
No, specific, what I want to say is that this misuse of the workers' fund should be avoided. And therefore, increase in the dispensaries is more important. What the various panelists have made the point, I accept that, and that should be taken forward in our campaign. That's, I can tell
you. Thank you. Thank you, sir. Thank you so much.
Yes.
We would like to hear from others if there are anybody who would like to. Yeah, I can see Gokul from CVW raising his hands. Gokul, please go ahead.
Hi. Can you hear me all?
Yeah. Yes.
Yeah. Thank you to the WBC, the organizers, and thank you to all the three speakers. I mean, the session has been very enriching information-wise. So my question is, I would like to pose a question and learn from the speakers and other participants with respect to this campaign, how we can use the state and district level ESI committees to know how can we use these committees to lobby and take it forward this campaign. Yeah.
Thank you, Gokul. The speakers will be sharing their comments in the end. We'll just take the questions and questions together first. So if there are any more questions for clarification, please kindly raise your hands.
Also, I would like to ask Gokul if you want to direct this question to specific speaker or it's open for all.
It's open for all. Yeah.
Okay.
Hi, this is Vaibhav. Can I make a few points? I don't have a question. That's all.
Yes, please, Vaibhav.
Hello, Sundra Babu.
Yep.
So thank you to all the speakers. I think between all the speakers and the comments that have been made after that, a lot of ground has been covered. One point was made whether the government intends to sustain ESIC or intends to weaken it. On that, it's a larger political discussion that I won't go very far into, but I just, from what I have seen over the last 3-4 years, is it should be seen in the larger context of what is happening in the health sector, particularly with the private insurance sector and private healthcare providers who seem to not be doing so well financially. And the assumption that ESIC and the government has had for a long time is because beneficiaries are registered and they are regularly paying contributions. ESI has a captive base of about 134 million consumers, so to say, right, who are not being serviced because of ESIC's current state of functioning. So it is a possibility that the government may be interested in changing the role of the ESIC, not eliminating it, to facilitate the rechanneling of this captive user base to the private sector, either through service providers or to private health insurance firms who can be given some role or the other within the ESIC system. But this is for senior leaders to decide politically what appears to be more probable. But I have 2 more points to make. The second point I want to make is that as I've had the privilege of working with Dr. Sundaraman here and also on the ILO study he cited with Dr. Shaktivel Selvaraj. And what we have found that this assumption of ESI having a captive base of people with health needs is not true, because a large section, I think the majority of the beneficiaries who reported having ESI cards and an ESI facility within 10 kilometers of their residence still did not use the ESIC facilities. they still went to either the public sector dispensaries or hospitals or the private sector. So this assumption does not hold that whoever is paying for ESIC, even if services are available, will use ESI services. That is not happening on the ground. So this is where I think for a campaign, there is a common ground that you can find with the government, because the government is definitely keen on increasing the utilization of ESI services. Only then it becomes attractive even to the private sector if they are to join the scheme in any way. So in that sense, it is the captive demand that we need to focus on. And when we talk of the unorganized sector, it's a behemoth. It's a very diverse group that we are talking of. But within that, there are already currently eligible categories of workers like the contract workers that were mentioned, who are legally covered but are not getting services or not even getting enrolled because employers don't let them. There are, municipal corporation workers, sanitation workers have recently been entitled to getting ESI benefits. I mean, this has happened in the past also, but it was announced again a couple of years back. I don't think most municipal corporation workers are accessing ESI services. There are shops and establishments which are covered under ESIC under Section 5. We don't know many. At least I haven't heard of many shops and establishment workers who are using ESI services. More recently, the Labor Code has committed to covering gig and platform workers and plantation workers in specific. Now, just taking these examples, it's a huge population of unorganized workers who are currently entitled to the ESI benefits but are not being covered. So if a campaign has to actually focus on achievable concrete results over the next few years, it is these categories maybe that we could start with, right? Helping them, getting what is their right under the current system. Forget about those who are currently not covered. That's a longer battle. Now, one thing at the end that I want to point out, that unlike, it's like Professor Sundaraman said, it's not a health insurance scheme. It's a comprehensive social security scheme backed by a legislation. So it's also not like a simple scheme of the government that can be withdrawn at any time. We have seen efforts to change its form in the Social Security Code drafts. There were various proposals of all kinds, but ultimately the scheme was retained as largely as it is. But we should also remember that the scheme is being run by a standing committee as well as by regional boards at the state level, which are tripartite. So there are trade unions who are involved in the management of the scheme for 70 years. And despite that, we have this condition of the scheme. So I think it is also time to look inward and work together with the trade unions who are on various boards at the regional board or at the central board. I was just looking, I think currently now it's changed. It's only BMS and TUCC who are in the central standing committee. But I'm sure at every state regional board, we have various unions who are representing workers in those boards. From what I know, those boards don't have regular meetings. And even if they do, their decisions are not implemented. So there is a very concrete system in which workers have a space to articulate their concerns. And it is up to us to start working with our partners in the labor movement who can actually help us reach out to these workers who keep waiting, right? Like I said, they are covered but not getting benefits. So that would be my input, adding to what other speakers have said before. Thank you.
Thank you, Vaibhav. I think we are on same page. I mean, the WPC position is very identical to whatever you have said. The Selvaraj study, only thing is that Selvaraj studies recommends many of these things. It's a very strategic position which they have taken, the ILO has taken, to put the government as a responsible person to bring out some of these changes. But what WPC thinks about the recommendations that ILO has made is where we have to play an interface role. So WPC has taken up that part to play the role in creating those awareness whichever you had highlighted in the study. So the last part of the study I've read it many times, and also Shaktivel is a friend, so we know what the ideas are. So as Professor Sundaraman already mentioned, that with regard to the intention and all those things, it's a very clear failed neoliberal model. That's something which we understand. But what we are looking at is the WPC's role into facilitating these gaps. So that's what we are looking at, and then we are trying to play a role in that part. So that's the thing. So thank you for the input, Vaibhav. Yeah, any more comments? Any more
there
questions?
are a few questions by Shweta and Anil from India Labour Line. So I would request them to please. Shweta, do you want to take your question? Okay, her question is there misuse of ESI funds? Are they mandated to construct nursing hospitals? And Anil from India Labour Line also has raised one question. My question related to ESI card, which most of the workers are unaware about. So, Anil, can you please explain that question again?
Thanks, everyone. Actually, my question is, when workers are calling here, they are asking companies deducting the ESIC amount from their salary slips. But thing is that they are not getting any benefit if there is, they don't have any knowledge how to utilize that benefit. If they hospitalize they are hospitalized, that time how it will be get benefited out of this, because even that employers also not giving proper information regarding this. This is my question, Chinmay.
Thanks, thanks, Anil. Thanks, Shweta. I think we can look up to the speakers to respond to these things. But the primary information is that every employer is mandated to give all this information to the workers. That's by law. That's something which these people are not following. But then we would like to hear from the speakers about these questions that have been raised. Professor Sundaraman, can you start with your inputs, please?
Thank you. I found it very wide range of questions. And let me give a few responses. I may miss some. I think this waste of money, which Prasanna pointed out, is a very good point. And part of the reason is, in a very bizarre way, people talk about this 99,000 crore surplus and what do we do? Shall we build hospitals? And there's a readiness to build infrastructure, buildings, because they have huge contracts and there is corruption involved, but not to provide human resources and services, care provision. So therefore, this whole thing to medical colleges that went up and then came down again is basically looking at this 99,000 crores not as a failure of service delivery or a need to strengthen primary care, which they don't understand anyway, but to invest more in what we call stone and mortar corruptions, and partly corruption, but partly also the dominant discourse is that healthcare is something of building big hospitals. And you're in occupational health, for heaven's sake, there should be some more intervention in occupational health. But that sort of thing isn't there in the thinking even of the labor unions. And that, I think, is something that we should really worry about. The second thing, and this is I say about labor unions, in the study that we did, I did get some interviews across. I found a very interesting thing. At the district hospital level, the tripartite system doesn't work too badly. Now, listen, I've not learned all over India. So I know where I've seen in Tamil Nadu, I've seen in Pondicherry, I've seen in some of these places where I could, it was reasonable. And they did some arbitration, they did some facilitation, they did some local problem resolution. The real failure of tripartite intervention is that they do not really understand or intervene at the policy strategy level, where I think the whole tools of doing so require a certain sophistication and governance that mere trade union thing does not prepare for. There is a need for an organization like yours to really look at policy briefs that have to be prepared on key issues, so which the trade unions can take forward and their representatives can take forward. This civil society to trade union interface is very weak, and it has resulted in so this importance of preparation of policy briefs for right to healthcare, for the patent waiver, for intellectual property rights. We've been doing that all the time in other sectors, but I feel I've not really seen that sort of expert input. And I think that we do need to, at the local level, they understand. The tripartite organization understands, but in the policy level, the intake is much more difficult. And sometimes they just sign on. In fact, one of the administrators told me, but why you are saying the administrator, when they've started medical colleges, the trade union signed on. When we said stop it, they signed on. They didn't ever oppose or offer any alternative policy. Whatever they say, they sign on. At some point, they are overwhelmed by the way policy gets presented by the senior administrators. I think that's one part of it. I think this is most exciting is your question that I have, where there was asked, how do we take it forward as a district level campaign? I mean, a lot depends upon your taking forward as a district level campaign. You may not be able to cover all the districts. Nobody can do that very easily, much less a civil. Even if you do some 5% of districts and you broadcast what you did in those districts, others will pick it up. So you need to actually measure the gaps between what is promised and what is delivered. Second, what is required and what is delivered and promised. These are two things. Okay, and what is required for providing the delivery of benefits is what we have been saying, talking about, and these needs to get into policy briefs for the local level. But the other one is, this is promise. This is, even the government understands, but the gaps on delivery. And therefore, I think there is a huge scope of such intervention. And once you do that, then it will also help the intervention at the national level, because most of these problems flow down from above. They are not problems of implementation. They are problems of strategy. And you can see them better if you engage at the district level in intervening and trying to take up the closure of the gaps between what is promised and what is done, and between what is required and what is done also. I think this question of people not using services which Vaibhav raised is a serious issue. And it helps to have the principle that people are rational. They do make choices which are rational. And therefore, if they are not using, what are the circumstances of their not using? And I think that you will find that the services available at the primary care level are a caricature of what should be available in terms of the depth, quality, intensity, the lack of the follow-up, the lack of backup. Many times the local medical provider is seen as somebody who gives the sick leave certificate rather than necessarily giving sickness care. And some problems like that. But basically, I think that this bears exploration, but they admit of rational reasons. And I have not actually been able to study it in the ESI, but in other areas I have seen, in the public sector, they talk of people bypassing PHCs and going directly to district hospitals because they think specialists attract them. No. That's not the issue. If you want to, you need a specialist consultation. The specialists say diagnosis, diabetes or epilepsy. And then you need to be able to take your weekly supply of drugs. But the weekly supply of drugs is not available locally. You have not got an appointment. You have not got systems. These are problems. Sometimes you need 2 shifts. A 24-hour running dispensary is still, a primary center is still a bit of a mile away. But you should be running by now in the same infrastructure 2 shifts, because many workers are working in shifts. And therefore, you will find that it's convenient to run with the same infrastructure, but double the human resource. You can actually provide a much higher volume of care, have a system of giving appointments to people, special days for management of chronic illness, and a huge number of things. You will find this problem of using services no longer exists. And you will find that your 99,000 crore surplus will immediately get spent. It will go into human resources, and it should go into human resources and services on that. So I think that these are some of the key issues that I will flag. And I think there is a role for engaging with a wider section on this awareness building of the rights. And on this question has not arisen here seriously enough. I'm worried about two things. One is we have not yet got a proper understanding of the integration of general public services and the ESI services. Even there are some states where the state health department runs ESI services. There are some states where the labor department runs ESI services. And there are some states where the central department runs ESI services. So the central labor ministry. So we have not enough handle on how it works out on many of these issues. We would also like to look at how at some point the referrals between these occur. Why that, for example, you are sent to a very busy general like Madras Medical College. Nobody would like to go, but what are the alternatives that are worked out on this? There are very many practical problems in the organization of care that requires to be addressed. I don't think, but this problem of integration is an extremely important problem. In Thailand, when they started the universal coverage service for general service, which covered 70% of the unorganized workers, the SSS system for the organized workers continued. Till today, it continues. At that time, it was 7,000 rupees, 7,000 baht per capita in the ESI equivalent system, and 2,000, 3,000 baht per capita in the general system. Now, both have reached the optimum level. Both are more or less the same, and people actually see both as equally performing. And the integration is much easier because people say in the local area, I'll prefer that. When I'm going to the urban city, I will prefer that. And such choices are possible on it. Whereas the central government scheme, which covers the military, is still at 18,000 rupee baht, more than twice the rest of it. But having said that, that integration to reach this level, and I've been following it up over years, has taken 15 years. They started with the preliminary thing as separate systems in 2004-5, allowing some sharing of the service delivery infrastructure below. But to reach a certain understanding, still it's not fully integrated above. But still the particular form at which it has taken to reach a very good mature form. If we reach that form, we have arrived. It's taken 15 to 17 years on that. So I think this problem of how do we take these services along is something that we will need to handle, and how this together will be UHC's answer. I think one of the things that most policy makers in the public health strengthening system are missing is the contribution that the ESI system can make to the achievement of right to healthcare. They're really, because they have not been exposed to it either. The civil society is very active there, knows very little about the ESI system. And this is to the loss of both. Both people lose because of that. So I think these are some thoughts. Thank you.
Thank you, sir. Thank you. We are running short of time. I would like to hear from Mr. Mohan Mani and Dr. Amit Basode some more reflections on this.
Go ahead, Mr. Mohan Mani, please go ahead.
Oh, okay. I don't think I have much to add after Sundaraman's rejoinder, which was extremely useful. I learned a lot from that also. I just want to add a couple of things. One is that, yes, why is it that that ESI clinics don't get, I'm using the term clinics instead of dispensaries, ESI clinics get used less? Partly it is because of the timing, as Comrade Prasanna said. There are clinics which actually work on staggered timings. You can have clinics with say, two shifts, a staggered timing of say 7 to 11 and 3 to 5, which actually, and 3 to 7, which actually operate, because workers need time to be able to come to the clinic, not only for their own ailments, but for the ailments of their dependents. And you don't get time off from work for looking after those who are family members. So yes, this is something that needs to be addressed. The other question is, the other thing about why clinics are not used is the lack of doctors. And here there is, yes, what Dr. Sundaraman said, underfunding, yes, sure. But there is also the question of doctors being reluctant to go to rural areas, particularly where the rural areas are, there is a considerable difference between the cities and the rural areas. So you may find that in areas near Chennai or in most parts of Kerala, there would be doctors who are willing to go to what is called rural, but what is actually semi-urban. But when you go to a state like Bihar, are doctors willing to go? So you need a fundamental rethink of our medical education system. You have, even in the US now, you have a category of medical care providers who are essentially called who are essentially, in a sense, paramedicals who are but in India we don't the medical system has not allowed for any form of barefoot doctors or the medical care providers who would be willing to go out and work in areas where the urban doctors are not willing to go. So this is a serious question which I think needs to be addressed. I don't know what can be done about it. There is a whole medical care establishment which stands against it. And this is something that we need to look at. I will leave it there. Amit?
Thank you. No, I also don't have much to add. It has been an extremely enriching discussion for me. I was a bit wondering, what am I doing here? Because I don't have much to really, educate. I come away having learned a lot. And I'll just say that, particularly to the WPC and other folks who are doing the campaign, that, if there's something that we can do, which is obviously not the particularities of the way the institutions work, because that's not our strength here. But if you'd like our assistance in any other respect, with respect to making the case financially, macroeconomically, there's always the question of, can we afford all these kinds of things. So if there's anything that we can do in that respect, please let us know. Otherwise, I have really nothing more to add. Thank you. Thank you for having me.
Thank you so much. It was a very enriching discussion that we had. Is there anyone else who just want to add just 1 or 2 minutes more to be brief? Or if there is nothing much, we can move to closing on this important webinar. Some key takeaways, like one of the things which this discussion thrown light was on this interventions at the grassroots level. As a strategy, WPC already has, we are in the midst of the campaign. We had certain initiatives made last year. We submitted a petition to the Prime Minister asking for expansion of the ESI rights to all workers. It was signed by more than 300 organizations across the country, and we intend to resubmit the petition again in a revised format with at least 500 organizations. So in that, we had demanded that it should be more inclusive. All workers should be included. It's in line with the ILO's thing that no workers is left behind. So that the social protection covers all. So in order to make things more clearer, we requested the government to start with the workers who are registered with the eShram. The eShram platform covered some level of workers. At least start with them because you have some data on them. So let us use this digital advantage to provide or expand the coverage part. That was one thing which we asked for. And there was this discussion on the cap question, the cap of 21,000 last year, but then we could not resolve it. But we thank Professor Sundaraman for throwing us some more light on that. It gives us clarity now to demand for removal of such things, because as a welfare state, it does require that it should cover all. And it is complementary to the SDGs and the ILO conventions and etc. All those things are in tune with these demands. with the suggestion that came out on working with the district level interventions, we already some of these points came in our deliberations in different states. So many people in different states suggested that we take up campaigns at the constituency levels, looking at the MP constituency and looking at the assembly constituency. So that we put pressure with the politicians there. We put with pressure with the MLAs and MPs, or the aspiring MLAs and aspiring MPs, to take this up, so that we demand a full-fledged hospital in each of these MP constituencies, and the primary health centers, at least the primary health centers in all assembly constituencies. That was the kind of a demand that people suggested. And to experiment on this, we are trying this thing with Karnataka. In the Karnataka state assembly elections, few of our civil society groups in Karnataka, the WPC members in Karnataka, are willing to take this up and try it out with the assembly constituencies. In few of the assembly constituencies, they want to put this demand with all the candidates who are aspiring to contest in this election. So that's one thing which is concretely coming up in the coming days. And thanks, Professor Sundaraman, for this clarification on this dispensary clinic and the PHC's issues. I mean, what we should demand, we should always scale it up so that the government looks into that. Otherwise, they try to dilute it as much as possible. And also Mr. Mohan Mani's suggestion about the capitalization or recapitalization thing, which appears to be a kind of a plot in dismantling the whole ESI structure. So that's a very valuable input. And in our campaign calls, we have mentioned this, but your points give us much more clarity, and we can include some more specific points. And we are thankful to also Dr. Amit Basole, because though he didn't tell some of the points today, but he has given us a very detailed paper on it, on the whole finance part of how we work, how we can work, how WPC can take it up and work on the financial dimensions of the ESI campaign. So thank you so much to all the key speakers. Also, the suggestions that came from our participants about looking at 24-hour service of ESI. So that's again a very valuable addition. I mean, why not demand that? So at least in some places, because we do know that after a recent audit in Delhi about a prominent ESI hospital, we found out that it was not fit for the fire service, the provisions which the fire service has set. So it was unfit. They gave an unfit certificate for the hospital. And another hospital in Bombay, which had a fire accident some years ago, it has not been restarted. It has not been given clearance yet. And so it's almost 4 years there. So these are also the issues which are there with the infrastructure, the pathetic situation in which some of this infrastructure exists. So all these dimensions are there, part of our campaign. And we are thankful to also Vaibhav for his inputs, because some of our positions are in line with the last year's ILO study, which we are also emphasizing on the gender component of this whole thing, because the newly the membership that has increased in recent years has a lot to do with the gender question, but it does the system has not adapted to that part. So we are also looking at, and we are also looking at the bottoms up approach to improving service, and also in the last few months, we have been deliberating upon the linkages between occupational safety, health, in the context of ESI. So we are also working on a dedicated campaign for training these linkages between occupational safety, health, and ESI provisions in our sector, in the sector where we are working. So these are the things which have come up in recent times. So the inputs are very valuable. So thank you so much, everybody, for this enriching meeting today. Thank you all.
Thank you.
Thank you.
Chinmay, do you have anything to say?
No, that's. Oh, I think we are done for today.
Right.
But I would request all the participants, if they have any more questions that they want to ask to speakers, then I have sent one mail ID in the chat box. They can send their questions in that mail, on that mail ID, and we will coordinate that with the speakers. Yeah. Thank you.
Thank you, Professor Sundaram, because he has already sent the presentation while we were speaking. So thank you so much. We will be sharing with our people. We will be translating it as well to vernacular languages.
Thank you.
Thank you. Thank you, sir.
Thank you.
Thank you. Bye-bye. Thank you so much.